All right, welcome everybody to the 2019-2020 SAGES SCORE Webinar ABSITE Review Part 1. My name is Michael Awad. I'm very excited to host this special event. This is our 5th year hosting it, and it's been an incredible opportunity to do this. We have over 2,000 people across the world from about 31 countries that are joining us today for this webinar. So thank you all for making time to be a part of this, and we have a lot to go over, so I think we're going to go ahead and dive in. So just a quick outline. Again, my name is Michael Awad, but I'm joined by a series of tremendous expert faculty in these various topic areas, and Dr. Blatnick, Dr. Traugut, and Dr. Vreeland, which I'll introduce to you each as their section comes up. Tonight we're going to be going over a variety of topics that will be featured on the ABSITE, which will go into more detail. The ABSITE webinar is sponsored by two organizations, SAGES, the Society for American Gastrointestinal Endoscopic Surgeons. SAGES is one of the premier surgical societies focusing on minimally invasive surgery, a tremendous organization that I've been proud to be a member of for over 18 years. Just a note, the next SAGES annual conference is in April in Cleveland, Ohio. It looks to be a terrific program. And as an aside, SAGES has been really a tremendous supporter of resident education, and I would really encourage all of you who are not members to consider looking into the society. I'd also like to acknowledge our co-sponsor, which is SCORE, the Surgical Council on Resident Education. SCORE has also been a tremendous supporter, as you know, for resident education for many years, and has really developed the only national surgical curriculum for resident trainees. So SCORE has kindly provided the questions, for these, and these are novel questions that you haven't seen before, so we're very appreciative of that relationship. Our ABSITE content outline is shown here. This is from the American Board of Surgery, and this shows the topics that are in the patient care categories on the ABSITE. Our goal for tonight's section, part 1, we're going to cover abdomen and alimentary tract as well as endoscopy. And then by popular demand, we're actually going to have a second ABSITE webinar in January. And that is meant to cover the remaining topics on the content outline. So on January 14th at the same time, we're going to be covering the remaining topics. Together, all of these webinars will cover really 72% of the entire ABSITE content and all of the patient care categories. Now, we've used this audience response system for many years. This is a multiple choice question and answer system that we're going to be using for all of our questions. We're going to go at a pretty good pace, but we found this to be interactive. So while I'm just kicking off here, I'd encourage everybody to go to the following website, pollev.com/ABSITE, pollev.com/ABSITE, or you can text ABSITE to 22333, and then once you join, you can use A, B, C, D, or E. We're going to go through some questions and answers, and then we'll go through the rationale once we're done. A couple notes: if you lose any audio or video, please exit the webinar, close out of your browser, launch your browser, and then log back in. If it continues, restart your machine. At the end of the webinar, we're going to have a link to a survey. We really, really would appreciate your feedback on the webinar, and please complete the survey once this is done. And finally, this webinar is being recorded, and it will be available within the next 2 weeks at www.sages.org if you want to review the webinar. So I think that's all of our housekeeping things. Again, I'm Michael Awad. I'm a minimally invasive surgery faculty Washington University in St. Louis. And I'll be kicking off with the esophagus, stomach, and obesity topics. All right, so our first question, 72-year-old male with a prior history of stroke was referred to your clinic for symptoms of dysphagia. He reports difficulty swallowing his food. He feels like the food's getting stuck in the back of his throat. He's been hospitalized 3 times in the past year for recurrent pneumonia. He often coughs after eating. Which would be the most appropriate next diagnostic test? So go ahead and answer modified barium swallow, esophageal manometry, EGD, CT of the neck and chest, or upper GI series. Okay. So the correct answer is modified barium swallow, and you can see kind of the range of responses there. Modified barium swallow is the correct first test, and the reason for this is you're trying to sort out why he has what appears to be oropharyngeal dysphagia. There is a concern of some upper esophageal process with the coughing and with eating recurrent aspiration events. Obviously, one of the concerns here is the Zenker's diverticulum. An EGD is also a reasonable choice, but there is a concern that if you don't know there's a Zenker's, you could perforate it if you're not careful doing the EGD, so the modified barium swallow can pick that up first. An upper GI series is a little bit more than what's necessary as far as a contrast swallow, because that also images the stomach as well as the first part of the small bowel. All right, next question is a 53-year-old man who underwent an endoscopic ultrasound. It was found to have a 6-centimeter submucosal gastric mass that was biopsied. It stained positive for c-KIT with 8 mitoses per high-powered field. His tumor has most likely spread to A, the spleen, B, the spine, C, the periaortic lymph nodes, D, mesenteric lymph nodes, or E, liver. Okay, see a lot of responses coming in. There is indeed liver. So this is a gastrointestinal stromal tumor, or GIST. These tumors usually spread through hematogenous routes, often most commonly to the liver and to the peritoneal surfaces. They do not spread through the lymphatics, and also don't commonly go to the spleen or the spine. All right, next question is also about a GIST. This is a 56-year-old woman who was diagnosed with a 3-centimeter GIST in the greater curvature of the stomach. The tumor has a moderate mitotic index. What is the best next step? Endoscopic resection, gastric wedge resection with 5-centimeter margins, gastric wedge resection with R0 or R1 margins, imatinib followed by gastric wedge resection, or no surgery with imatinib alone. Okay. Yes, the correct answer is C, gastric wedge resection with R0 or R1 margins. For gastrointestinal stromal tumors, unlike adenocarcinoma, you don't need 5-centimeter margins. nor do you need lymphadenectomy. Imatinib is, or the brand name known as Gleevec, is useful in the adjuvant treatment of large GISTs with high mitotic indices, but for smaller GISTs, surgery alone can be curative. Imatinib also doesn't have a role for neoadjuvant therapy in smaller GISTs, although there's some thought that it may be helpful in very large GISTs prior to surgery. All right, the next patient is a patient with hematemesis who's taken for endoscopic evaluation 15 hours after becoming septic. Multiple shallow lesions in the gastric mucosa are seen at the level of the fundus with discrete areas of erythema and focal hemorrhage. What ulcers are most likely in this patient? Cushing ulcers, curling ulcers, early stress ulcers, H. pylori-induced peptic ulcers, or late stress ulcers. All right, very good. These are indeed early stress ulcers. Again, this is a septic patient with early stress gastritis. Usually these occur in the first 24 hours after an insult such as shock or trauma, hemorrhage, or sepsis. Cushing ulcers, in contrast, are usually single and deep. And curling ulcers are most commonly seen after burns to more than 30% of the total body surface area. H. pylori ulcers are most commonly found in the duodenum and are associated with chronic gastritis. And late stress ulcers are usually 24 to 72 hours after the initial insult. Our next question is about a 32-year-old man who reports that his father just underwent successful surgery for stress gastritis. He is concerned that he will develop this condition. What are two factors that put patients at greatest risk for stress ulcers? Prolonged ventilation and glucocorticoid therapy, head trauma and history of peptic ulcer disease, head trauma and coagulopathy and prolonged ventilation, or glucocorticoid therapy and history of peptic ulcer disease. Good. A lot of variability on this one, so let's talk about that. So coagulopathy and prolonged ventilation more than 48 hours are the factors that put patients at the greatest risk for stress ulcers. Head trauma and history of peptic ulcer disease are both risk factors for stress ulcers. However, they've not been shown to have the highest risk. Steroid therapy alone has not been proven as a risk factor for stress ulcers. However, it may increase the risk in the presence of other risk factors. So in this case, the correct answer is D. All right, our next patient's a 75-year-old woman who's referred to your clinic for symptoms of dysphagia. She says that she's been having difficulty swallowing certain foods, coughing after eating, and feeling as though food sticks in her throat. She has had several episodes of pneumonia over the past year. What would be the best initial diagnostic test? CT of the neck, EGD, esophageal manometry, modified barium swallow, or upper GI series. Very good. You guys are learning quickly. So well done. I'm not going to spend too much time on this. This is very similar. Obviously, this is concerning for another Zenkers. And as we discussed, modified barium swallow is the correct initial diagnostic test. All right. Next is a 82-year-old woman with a history of cervical stenosis who presents to your office to discuss surgical options for surgical management of her Zenkers. She's had multiple episodes of pneumonia over the past year. On physical exam, she is unable to fully extend her neck due to prior history of cervical stenosis. What is the best approach for treatment? Endoscopic repair of the Zenker diverticulum, diverticulectomy without myotomy, observation, Dolman procedure, or diverticulectomy with myotomy. Okay, so let's talk about this one. So, this is obviously, again, our Zenker's discussion and rounding this up. The issue here is that because the patient's octogenarian with cervical stenosis, she can't fully extend her neck. This makes the traditional endoscopic repair through rigid techniques very difficult, if not impossible. I noticed a number of folks answered A, and we can talk about that here in a second. When we do an open repair, myotomy of the proximal and distal thyropharyngeus and cricopharyngeus muscles is performed. With a small diverticulum, you can just do a myotomy, but with the larger one, you want to resect the sac as well as the myotomy. Now, having said that, so the traditional answer would be E. A number of you answered A, and there are some new flexible endoscopic techniques for Zenker's diverticulotomy that may be an option for these older patients with cervical stenosis. You have to watch out. If it's a very, very big pouch, you may have to resect it nonetheless. So, but in this case, the correct answer is E. All right. Our next patient is a 78-year-old man undergoing an open myotomy with diverticulectomy for large Zenker diverticulum. On the third postoperative day, however, he begins experiencing worsening back pain with a temperature of 101.3 Fahrenheit, heart rate of 125 beats per minute, blood pressure of 82/60, and oxygen saturation of 88%. What is the most appropriate initial management? Nothing by mouth, fluids, and antibiotics, immediate return to the operating room, modified barium esophagram, CT of the neck and chest, or gastrographin swallow study. Immediate return to the operating room. All right. Very good. So the key with this question is, and as with a lot of ABSITE questions, what is the most appropriate initial management? And so a number of you answered B, and while that may indeed be what's necessary in this case ultimately, that's not the very, very first step. So again, this is a patient who had a Zenker's diverticulectomy. We're worried obviously here about a leak with his tachycardia and fever. And while the other interventions are possible, obviously we want to involve fluid resuscitation, initiation of antibiotics. Now, if the patient's stable, you can do a study to confirm the leak, like a gastrographin swallow study or a CT. But if the patient is also stable, you could also elect to manage them with NPO and expected management with the results. If they're unstable, obviously they have to go to the operating room for exploration and repair of the leak. All right, and then rounding out our kind of upper esophageal section, we have a 67-year-old woman with Zenker's. who undergoes an endoscopic repair. 1 month later, she presents to your office for continued episodes of coughing with eating and dysphagia. What is the most appropriate next step? Repeat barium swallow, esophageal manometry, EGD, CT of the neck and chest, or observation. All right, excellent. So the correct answer is A, repeat barium swallow. Unlike our previous patient, this is a chronic situation with concerns for a residual diverticulum. And so a barium swallow would be an appropriate first study, just like we talked about, even before you do an EGD to see if that's the case. All right. Now you're called to the recovery room to evaluate a 54-year-old man who just underwent a endoscopic EGD dilation of a mid-esophageal stricture. He is now complaining of worsening chest pain, dyspnea, and dysphagia. What would be your surgical approach to repair his esophageal perforation? A right posterolateral thoracotomy, right anterolateral thoracotomy, left posterolateral thoracotomy, left anterolateral thoracotomy. All right, very good. So a right posterolateral thoracotomy would be the best approach. We're concerned about a perforation of the middle third of the esophagus, and because the patient already had a known mid-esophageal stricture, this is the most likely site. Left posterolateral thoracotomy would be used for perforation in the lower third of the esophagus. All right. A 40-year-old man presents with complaints of diaphoresis, palpitations, and tremors approximately 3 hours after meals. He underwent surgery for a perforated gastric ulcer about a month ago. You test his blood sugar, which is found to be 50. He responds to intravenous dextrose, what is primarily believed to be the hyperinsulinic response. A, fats, B, carbohydrates, C, proteins, D, amino acids, or E, fatty acids. All right, very good. This one we won't spend too much time on. I think people got that this is a dumping syndrome, which is usually related to carbohydrates being rapidly delivered into the small intestine. It's a very similar profile to insulin shock. All right, let's go on. A 65-year-old man presents to the emergency department with new onset severe abdominal pain. Chest X-ray shows free air. As you explain the likelihood of a perforated peptic ulcer and the need for surgery to him, he displays great concern over the possibility of a malignancy. Which of the following is most likely to be cancerous? A 4-centimeter perforated anterior duodenal ulcer, 3-centimeter perforated gastric ulcer, 2-centimeter recurrent duodenal ulcer that's failed medical therapy, 1-centimeter gastric ulcer near the GE junction, or 1-centimeter gastric ulcer near the pylorus. All right, good. So the correct answer is B, a 3-centimeter perforated gastric ulcer. So let's take a minute to talk about this one. Gastric ulcers that resisted medical therapy or severe enough to perforate are increasingly concerning for possible malignancy. So all gastric ulcers really should be biopsied to rule out cancer. The larger the ulcer, the greater the risk that it is malignant. Although a malignancy at duodenal ulcer is much rarer, biopsies should still be taken and sent for pathology. All right, next is a 60-year-old woman with a long history of taking non-steroidal anti-inflammatory drugs for arthritis, and then comes to the emergency department with severe epigastric pain. She's peritoneal signs on examination. Chest X-ray shows free air under the right hemidiaphragm. You take her to the operating room and find a 1.5 centimeter perforation in the first portion of the duodenum. What is your next step? Gram patch repair, primary repair with vagotomy, antrectomy with truncal vagotomy, antrectomy with Billroth 2, or primary repair with Roux-en-Y. All right, almost grand slam on this one. So I think you all know the management of a perforated duodenal ulcer with a gram patch. The only thing to add of note is if you know a patient that is negative for H. pylori and has failed medical management in the past for ulcer disease, then they should also have an acid-reducing procedure like a vagotomy and pyloroplasty in addition to the gram patch. But that is not this case. All right, you are reviewing an upper GI study in clinic when your attending decides to ask you to name the important things to identify on such a study for patients with reflux disease prior to potentially offering an operation. What would you reply to your attending? Lower esophageal sphincter pressure, location of the GE junction as well as the presence of a hiatal hernia, bowel anatomy, or three-dimensional evaluation of the esophagus. Okay, so the correct answer is B, location of the gastroesophageal junction as well as the presence of a hiatal hernia. So, an upper GI study really allows for the assessment of the location of the GE junction, presence of hiatal hernias, somewhat esophageal motility, although that's not the best test, as well as gastric morphology and possible volvulus. All right, one more question in this section. A 45-year-old woman with a long-standing history of gastroesophageal reflux disease who takes 20 milligrams of a proton pump inhibitor is sent for upper endoscopy by her primary care physician. Biopsy of a suspicious area on endoscopy returns as intestinal metaplasia with low-grade dysplasia. Which of the following is the most appropriate course for this patient? Continue current therapy and repeat endoscopy in 5 years. Perform esophagectomy due to dysplasia and concern for adenocarcinoma. Repeat endoscopy with biopsy every 6 months for surveillance. Treat any Helicobacter pylori infection. Or refer for fundoplication because that would allow the patient to stop having EGDs for surveillance. Okay, very good. So most of you got this one right. So, we're worried about intestinal metaplasia, which is otherwise known as Barrett's esophagus. Especially with low-grade dysplasia, they should be followed endoscopically every 6 months. Although innocent fundoplication does limit the need for additional endoscopies, there's not a clear role to eliminate routine surveillance. because it does not completely eliminate the dysplasia. All right. Well, I think that will conclude the stomach and esophageal portion of our presentation. I'm going to go ahead and move ahead to our next presenter, who's Dr. Jeffrey Blatnick. Dr. Blatnick is one of our partners here at Washington University in St. Louis, hernia and abdominal wall reconstruction specialist, as well as leader in SAGES. Dr. Blatnick is going to lead our next section on general abdomen, hernia, and spleen. Welcome, Dr. Blatnick.
Thanks again for having me. This is really a great program, having been involved and seeing how it's grown over the last couple of years. Really something I wish we had when I was resident studying for the ABSITE, and for you guys adding the second session, I think will be really helpful to expand on these topics. So we got about 20 questions we're going to get through today. You'll kind of see there are some themes as we go through, and as we get to different areas, we'll spend some time and go over those. So let's jump right in. The first question is a 51-year-old woman with chronic atrial fibrillation on warfarin presents to the emergency department with abdominal pain of acute onset. Her pain is worse with contraction of the rectus muscle, and a CT scan shows a circumscribed lesion under the anterior fascia of the abdominal wall. What's the most likely diagnosis? A, abscess, B, diastasis recti, C, hematoma, D, hernia, or E, lipoma. Good. It's a good start for everybody. Yeah. So this patient has a hematoma. You know, they kind of give you suspicion with the fact that they're anticoagulated, and they come in with a circumscribed lesion that's under the fascia of the abdominal wall. So this is kind of diagnostic for a hematoma. This can come from anything from the superior inferior epigastric vessels or their branches. You know, you want to make sure you get a full history and physical exam looking for any trauma or anything to the area. Sometimes you'll see it on inpatients if they get heparin or a Lovenox shot. That can also be an inciting event. So you want to keep an eye out for that as things go on. Let's move on to the next question. No, I forgot. There's a CT scan of kind of what you'd expect to see as you go through looking for patients. All right, next question. The 49-year-old woman with a history of type 1 diabetes presents with bilateral lower abdominal pain. She is also diagnosed with a rectus sheath hematoma, and CT scan shows hematomas in both the left and right lower quadrants of the abdominal wall. Her vital signs are within normal limits, and she has a slight decrease in her hemoglobin. How would you classify this hematoma? Type 1, type 2, type 3, type 4, or type 5?
Looks like this one needs some explanation.
So that's a good question. So I think if you jump to the next slide, I added a little table in there to kind of go over the different types of things. So there's really 3 types of rectus sheath hematoma. So they kind of mess with you a little bit by adding type 4 and type 5. But type 1 is a small and confined within the rectus muscle, and it does not cross the midline or dissect fascial planes. Type 2 is confined within the rectus muscle. However, it can dissect along the transversalis fascia plane or cross the midline. So that would be the correct answer for this patient. It's type 2. Type 3 is usually below the arcuate line. It's quite large in size and presents with blood either in the prevesicular space or of Retzius or in the hemoperitoneum. So there's 3 major types. Really depends kind of where it's located. Type 1 is probably the most common one you will see. Type 2 can cross the midline, and type 3 is either in the space of Retzius or hemoperitoneum. Next question. Is a 79-year-old man on warfarin for atrial fibrillation presents with a large ecchymotic abdominal mass that crosses the midline. CT scan also shows blood in the prevesicular space of Retzius. He's diagnosed with a rectus sheath hematoma. He is tachycardic and hypotensive and only transiently responds to fluid resuscitation. In addition to anticoagulation reversal and blood transfusion, what other intervention would you consider next? The answer: exploratory laparotomy with hematoma evacuation, angiography with therapeutic embolization, admission for close observation and serial hemoglobin, continued fluid resuscitation in the emergency department, or discharge home. Great. So that's the correct answer, angiography with therapeutic embolization. So this is, we learned in the previous question, would be defined as a type 3 rectus sheath hematoma. Treatment of patients with rectus sheath hematoma who are hemodynamically unstable can be angiography with therapeutic embolization. Obviously, we're going to reverse his anticoagulation and give blood transfusions as warranted. In the majority of affected patients, you usually don't need to proceed to surgical intervention. However, sometimes surgical drainage with ligation of an identified bleeding vessel may be indicated if they're unable to be successful with angioembolization. All right, we're going to close this out here. This is an 81-year-old man who presents with abdominal pain 3 months after undergoing prosthetic mitral valve replacement. CT scan confirms the presence of a rectus sheath hematoma without active extravasation. What is the next step in management? So similar things to what we saw in the last question: exploratory laparotomy with hematoma evacuation, angiography with therapeutic embolization, admission for close observation and serial hemoglobin, continued fluid resuscitation in the emergency department, or discharge home. Correct. So I mean, I think this one makes pretty good sense. I think this patient warrants admission to the hospital for observation and serial hemoglobin. We know that he has a recent prosthetic valve just 3 months ago. Presumably, you would assume he's on some sort of either anticoagulation or antiplatelet medication. So I don't think discharging him home would be the right answer for him. So yes, he should get admitted for observation. For those of you who are having trouble reading some of the questions, you can always pull them up also on the Poll EV website. They're there at the same time, and it may be a little bit easier to see. All right, so let's change gears a little bit. I think we've done enough rectus sheath hematomas. So the next question is, you're planning to place a peritoneal dialysis catheter in a 70-year-old man with chronic kidney disease, stage 5. His surgical history is notable for a cholecystectomy and umbilical hernia repair. What is the ideal location for placement of the peritoneal dialysis catheter tip? A, in the preperitoneal space, B, in the retroperitoneal space, C, in the left upper quadrant by the splenic hilum, D, in the right upper quadrant by the diaphragm and the liver, or E, in the pelvis. All right, good. So yes, the correct answer is E, in the pelvis. So placement of the tip of the catheter in the pelvis allows for optimal function and minimizes the risk for a mental entrapment, which can ultimately affect the ability for it to filtrate. Using the pubic symphysis as a landmark, the abdomen can be marked preoperatively to allow for proper incision planning and catheter placement. For me, sometimes even when I do these, not necessarily in the context of the question, but a lot of times we'll also do an omental pexy of just pexing the omentum in the upper abdomen to help keep that out of the tip of the catheter as well. But for this question, they're looking to place the tip of the catheter down in the pelvis. Next question is, a 25-year-old woman presents to the emergency department with intense left lower quadrant abdominal pain and nausea. She says that the pain began several days ago as colicky pain. However, over the past several hours, the intensity has become more severe. She has vaginal bleeding currently and says that her last menstrual period was 6 weeks ago. Her surgical history includes 2 cesarean sections and a tubal ligation. What is the most likely diagnosis? Small bowel obstruction, appendicitis, ectopic pregnancy, diverticulitis, or ovarian torsion? Correct. So I think what they're trying to get you or trying to trick you up on is that even though the patient's had a tubal ligation, it's still possible to have an ectopic pregnancy despite having tubal ligation in the past. Approximately 1/3 of pregnancies in women who've previously undergone tubal ligations are ectopic. Ectopic pregnancy is actually the most common cause for maternal death in the first trimester of pregnancy and accounts for almost 9% of all pregnancy-related deaths. Risk factors for patient to develop ectopic pregnancy are those who've had a previous ectopic pregnancy, previous infection with chlamydia, pelvic inflammatory disease, increased age, smoking, and prior tubal surgery. Next question is a 56-year-old man who presents with no past medical or surgical history, complaining of mild abdominal pain in the right lower quadrant for the last 2 months. On examination, there's a small area that's tender to palpation. You don't appreciate a bulge on physical exam. His workup included a CT scan which reveals a Spigelian hernia that is 2 centimeters in diameter. What is the next step in management? Surgical repair of the hernia, watchful waiting with reevaluation if the patient develops more severe symptoms, encouraging lifestyle changes such as weight loss and smoking cessation, colonoscopy, or EGD. Correct. So the appropriate next step would be surgical repair of the hernia. They don't really give you any information specifically that the patient is necessarily overweight or smoking, although ultimately those are areas where we do try to optimize patients prior to surgery. But since that's not really part of the question, ultimately surgical repair is important. You know, Spigelian hernias are hernias through the aponeurotic layer between the rectus muscle medially and the semilunaris laterally. They usually occur kind of right at or below the arcuate line and tend to present later in life. They're usually relatively small, just 1 to 2 centimeters, but should be repaired because of a high risk of incarceration because they have a relatively small neck. You know, a lot of times patients will present with similar symptoms that have gone on for several months, and since they are not full thickness through the abdominal wall, you may not appreciate a bulge or a clear hernia defect on physical exam, and this is where imaging, whether it's ultrasound or CT scan, can be helpful. And this would be an example of kind of what you'd see on laparoscopic evaluation. Next question. An 89-year-old woman presents with back pain and a reducible bulge on her back. What are the anatomic boundaries of the inferior lumbar petit triangle? 12th rib, paraspinal muscle in the internal oblique, 12th rib, paraspinal muscle in the iliac crest, 12th rib, latissimus dorsi, and the iliac crest, external oblique muscle, latissimus dorsi, and iliac, or the 12th rib, external oblique muscle, and latissimus dorsi. This is just an anatomy question, so it's stuff you got to know. All right.
Ooh, tough one.
All over the place. So for those of you, again, this is an anatomy question. There's no tricks in it. They're not trying to really fool you. They just told you what it is and want to know what the boundaries are. So an inferior lumbar or petit triangle is bounded by the external oblique muscle, the latissimus dorsi muscle, and the iliac crest. And so here's a nice little view of where that would be. Not a common hernia that you'll see very often. It's just one of those things that sometimes pops up on these exams that you need to be aware of. All right, next question is a 67-year-old man with a colostomy presents with a peristomal hernia that makes pouching the stoma difficult. He desires repair. Which of the following has the highest rate of hernia recurrence? Stomal relocation, laparoscopic mesh repair, open primary fascial repair, or open mesh reinforced repair? Okay, good luck. So yes, open primary fascial repair will certainly have the highest rate. Now, there's certainly some situations where this may be the correct approach, and somebody who presents either with, acute bowel ischemia related to their hernia or something like that. But for an elective-based repair, certainly open primary fascial repair will have the highest rate of occurrence. Stomal relocation, is also giving a primary opening through the fascia without any prosthetic reinforcement, but conceivably you're making a new fascial defect that's appropriately sized, and so just open primary fascial repair will have a higher rate of recurrence than stoma relocation. Next question, you're performing a ventral hernia repair on a 59-year-old woman and elect to perform a component separation with retrorectus mesh placement. As part of the anterior component separation, which layer of the abdominal wall is incised to gain additional length on the abdominal wall? The anterior rectus sheath, the external oblique aponeurosis, the internal oblique aponeurosis, Scarpa's fascia, or the transversus abdominis muscle? Correct. So the external oblique aponeurosis. So they kind of give you two terms in this question, whether it's intentionally trying to trick you or not. But they talk about retrorectus mesh placement, which a lot of people kind of attribute with being a posterior component separation, or what a lot of people refer to as a transversus abdominis release, or TAR. But they go on to specifically say as part of an anterior component separation. So, and that would be where you do an external oblique release in order to get additional medial advancement of the muscle. You can do an external oblique component separation and still do a retrorectus mesh placement. So the key here is just to make sure you kind of read the question real carefully and understand what they're trying to get at. So yes, external oblique aponeurosis is what you would release as part of an anterior component separation. Transversus abdominis muscle is what you would release as part of a posterior component separation. All right, so you're performing a laparoscopic ventral hernia repair on a 32-year-old woman. What's the appropriate amount of mesh overlap on each side, during a ventral hernia repair? Less than 1 centimeter, 1 to 2 centimeters, 3 to 5, 7 to 8, or more than 10 centimeters? That's correct. So 3 to 5 centimeters is your goal of what you want to get. 1 to 2 is really just not enough overlap, as most recurrences you'll see in an overlap of that amount would be just off the edge of the mesh. Additional coverage may or may not be beneficial, but I think at minimum you really want to aim for that 3 to 5 centimeters of overlap for laparoscopic ventral hernia repair with intraperitoneal mesh placement. Again, just as a reminder for those of you participating, put your question or your answers to the question in the Poll EV website as opposed to the chat room. And it sounds like a few people who've been having lag issues. You can always try logging back in through the app rather than through the website. That seems to fix most people's issues along the way. All right, so we'll try to keep moving here. As a 27-year-old man presents to your office with a complaint of abdominal pain and a persistent bulge, you believe you palpate a Spigelian hernia. At what location does a Spigelian hernia occur? Kind of covered this previously, so hopefully everybody will get this right pretty quickly. Oh, 99%. That's pretty good. Nice work, everybody. So that's correct. So that's the borders there. Option A describes a lumbar hernia of Grinfeld. Option B is the petit hernia that we talked about earlier. C would be an epigastric hernia, and D would be an incisional hernia by definition. All right, question 13 for my session. You are performing an open ventral hernia repair and are selecting the piece of mesh to use in the repair. Which of the following answers correctly pairs the type of mesh with the property of that mesh? A, polypropylene mesh becomes incorporated into native tissue. B, Vicryl or PGA mesh is non-absorbable prosthetic mesh. C, PTFE or polytetrafluoroethylene promotes tissue ingrowth. D, microporous heavyweight synthetic mesh has a high rate of bacterial clearance. Or D, biologic mesh is contraindicated for use in contaminated fields. As you guys answer this one, I'm gonna go on record and saying I really don't like this question very much, but we'll kind of talk through everybody's answers as you get there.
So what happens when you invite a hernia expert to the webinar? Yeah.
Right.
All right.
So that is the correct answer. So polypropylene mesh becomes incorporated in native tissue. That's what they want you to answer. So let's go through kind of some of these other ones real quickly. So Vicryl, that is an absorbable mesh. So that's the error in that one. Vicryl is an absorbable mesh. If you think about Vicryl suture being absorbable, Vicryl mesh is the same thing. A lot of times this is used for open bellies to just kind of bridge the abdominal wall and keep the viscera in place. PTFE or polytetrafluoroethylene. That is Gore-Tex mesh, or dual mesh is kind of one of the brand names that people have heard of. It's not used very commonly anymore and really does not have great tissue ingrowth. That's why it was actually one of the first meshes used for laparoscopic hernia repair, because it did not get good mesh ingrowth. Along the same lines, that's ultimately challenged by high infection rates and inability to clear it because you don't get good vascular ingrowth into the mesh itself. D, microporous heavyweight synthetic mesh has a high rate of bacterial clearance. You know, what they're trying to get at here is looking at the weight or the porosity of the mesh. Most people agree that a mid-weight or macroporous mesh has a better rate of bacterial clearance, although there's some mixed data, especially in kind of preclinical trials looking at this. But ultimately, that's what they're trying to get at here is the microporosity and heavy weight or density of the mesh. The last question, talking about biologic meshes contraindicated for the use in contaminated fields. Most people assume in a contaminated setting they'll use a biologic mesh because that's what it's indicated for. Technically, no mesh actually has an FDA indication for the use in contaminated fields, or even clean contaminated technically from that matter. So if you want to technically answer that question, ultimately, it does not have an indication as far as the FDA is concerned, but ultimately that is how it's used clinically, which is what they're trying to get at. All right, next question now that I'm done ranting about mesh for a little bit. After undergoing splenectomy for ITP, a patient has persistent disease concerning for a missed accessory spleen, and a technetium scan is ordered to localize it. Which is the most common location for an accessory spleen? Mesentery, the hilar region, the lesser sac, the diaphragm, or the tail of the pancreas?
This is a classic ABSITE question.
Yes, it is. Good. So yes, so the hilar region is the most likely area where you'll see it. And actually anywhere of 15 to 30% of patients with ITP may have accessory spleen. So I think that's really important as you're going through your rotations. If you end up doing a splenectomy for ITP, you want to take that time and look for accessory spleens, and then ultimately knowing where those are most likely to show up is really important. There is some mixed kind of data in the literature as far as the exact percentages. I think across the board everybody agrees that the hilar region is most common, where upwards of 50+% of accessory spleens can be identified. Most people after that considering the splenic vascular pedicle followed by the greater omentum as the most likely sources where you'll find it. Go on from there. So a patient is admitted 2 months after splenectomy and presumed to have post-splenectomy sepsis. The risk of overwhelming post-splenectomy infection is greatest in which of the following patient types? Answer A, I'm sorry, a 2-year-old child whose status post-elective splenectomy for ITP. B, a 16-year-old girl whose status post-traumatic rupture of the spleen after a motor vehicle crash. C, a 30-year-old man with HIV whose status post-splenectomy after a motor vehicle crash. E, a 20-year-old man whose status post-elective splenectomy for thalassemia. Or E, a 10-year-old boy whose status post-elective splenectomy for hereditary spherocytosis. I just want to know what patient population is most likely to get post-splenectomy sepsis. So that is correct. So post-splenectomy sepsis is greatest in the patients with an underlying hematologic condition, and the risk is higher in children than it is adults. So sepsis is seen particularly in children younger than the age of 15, and even more so in those younger than 5. So A meets those criteria. It's a young child who's 2 years old and had a hematologic condition. Next question, a 52-year-old man with a history of diabetes, hypertension, hepatitis C, and status post-motor vehicle crash is taken to the operating room for failure of non-operative management for a grade 3 splenic injury. Intraoperatively, you identify a capsular tear of approximately 2 centimeters. Your attending decides to attempt a salvage procedure. Which of the following is a relative contraindication for partial splenectomy in this patient? A, platelets less than 200,000 after 24 hours, B, cirrhosis, C, diabetes, or D, grade 3 splenic injury. So cirrhosis is certainly a contraindication for this guy. So the decision to perform splenectomy versus splenic salvage is made based on the grade of the injury, the presence of associated injury, the overall condition of the patient, and obviously the experience of the surgeon. So the small future risk of overwhelming post-splenectomy sepsis, really just you need to balance that against the significant risk for recurrent hemorrhage. Although partial splenectomy is infrequently used to manage splenic injury overall. There's no clear guidelines on what you should use for a splenic salvage procedure, but a partial splenectomy leaves behind a raw surface which may have an unacceptably high risk of recurrent hemorrhage, especially in patients with a coagulopathy or those who are at high risk for venous pressure, which you would see in portal vein injury or pre-existing cirrhosis such as this patient.
Dr. Blatnick, I want to thank you very much for leading us through that hernia section of the website, the ABSITE webinar.
Thank you. Thanks for having me.
All right, we're going to move on to the next part, which is colorectal and anal disease. I'm very pleased and excited to present Dr. Amber Traugott, a good colleague and friend who's at Ohio State University in Columbus, Ohio. Welcome, Dr. Traugott.
Thanks for having me. All right, so let's get started with the first question. A 29-year-old female presents to your office with a history of recurrent perianal abscesses requiring multiple previous incision and drainage procedures. She otherwise has no symptoms, no past medical history, and no relevant family history. The next best step in management of her condition is A, an MRI of her pelvis, B, a complete colonoscopy, C, an examination under anesthesia, D, a transvaginal ultrasound, or E, an endorectal ultrasound. Okay, and an examination under anesthesia, although I also see a significant number of you chose a colonoscopy, so let's talk about that a little bit. So this patient only has symptoms of these abscesses and hasn't had any other symptoms that would suggest an underlying inflammatory or neoplastic disorder, and doesn't have any history suggestive of those things. So really the first step you want to do is an exam under anesthesia to look to see whether she has a fistula as the cause of her recurrent abscesses, and if so, that could be treated based on the anatomy of the fistula. You wouldn't necessarily perform a colonoscopy unless you were having some sort of symptoms to suggest an underlying disorder. All right. Next question. A 40-year-old man with HIV and a previous history of genital warts is found to have an anal lesion consistent with anal intraepithelial neoplasia. Which of the following is the strongest risk factor for this diagnosis? A, HIV positive status. B, history of sexually transmitted infections. C, multiple sexual partners. D, human papillomavirus infection. Or E, underlying malignancy. Okay, so D is correct, human papillomavirus infection. Patients that develop genital warts and anal intraepithelial neoplasia, or AIN, almost always are going to have an HPV infection as the approximate cause of that. Being HIV positive puts the patient at a higher risk of developing more advanced neoplasia or cancer once they already have an HPV infection. But HPV infection is actually essentially required first. All right. A 56-year-old woman presents to clinic complaining of diarrhea. She states that for the past several months she's been incontinent of stool and has needed adult diapers. She has had no abdominal surgeries but delivered 5 children vaginally. What is the first step in management? A, overlapping sphincteroplasty. B, sigmoidectomy. C, medication and lifestyle modification. D, ultrasound. Or E, sacral nerve stimulation. Okay, good. So C, medication and lifestyle modification. That's what you want to address first whenever any patient has issues with bowel control. Many patients who have risk factors for incontinence will be completely asymptomatic as long as their stool is bulky and formed. And so medication and lifestyle modification can also encompass pelvic floor PT with biofeedback. And so these are the things that we start with because most of our patients will have at least some improvement with this, and it may kind of meet their lifestyle goals with these measures alone. All right. Next, a 61-year-old woman presents with a complaint of diarrhea. She reports that for several months she has also been incontinent of stool and has required adult diapers. She has had no abdominal surgeries, but states that she delivered 4 children vaginally. Initial management with medications and lifestyle modification has not improved her symptoms. What is the next step in management? So A, defecography. B, overlapping sphincteroplasty. C, artificial sphincter placement. D, endoanal ultrasound or MRI. Or E, an increased dose of loperamide. Okay, so let's talk about this a little bit. So the correct answer is D, endoanal ultrasound or MRI. So what you want to sort out in an incontinent patient is whether or not they have a sphincter defect that is contributing to their symptoms. A defecography study is going to tell you information about the mechanics of how their rectum empties, but in fact an incontinent patient is not going to hold on to the contrast gel very well that they instill in the rectum, and it's not going to give you much information about what surgical options the patient might have. So that's why you would perform some sort of anatomic study that would look at the sphincter complex itself to determine whether the patient is a candidate for a sphincteroplasty or not, because if their sphincter is intact, then they may have more of a nerve injury or some other mechanism that's going on, and you wouldn't offer that option to that patient. All right. So a 32-year-old woman presents to clinic with the complaint of diarrhea, who's also been incontinent of stool and requiring use of an adult diaper. She's had 5 children vaginally. After failing medical therapy, an endoanal ultrasound is ordered, and she is found to have an anterior sphincter defect. So what should be the next step in management? A lateral internal sphincterotomy, B, a diverting colostomy, C, overlapping sphincteroplasty, D, artificial anal sphincter placement, or E, DeLorme procedure. Okay, good. So that was relatively straightforward given the choices that you were given and the age of the patient. But I think it's important to note that if this patient were in her 70s, even in the presence of a sphincter defect, you would most likely give stronger consideration to sacral nerve stimulation if she were otherwise a candidate for that. We know that particularly in our older patients, overlapping sphincteroplasty does not tend to be a very durable procedure, even though it may have good short-term outcomes. And so we've now found that sacral nerve stimulator placement can give outcomes that are at least as good as those and can be more of a durable response. But younger patients who are closer in time to the time of their obstetric injury respond better than our older patients to sphincteroplasty, so that is a reasonable option for this young patient. Here's a diagram of an overlapping sphincteroplasty. So you can see that you have the retraction of the sphincter laterally, and the external sphincter is brought into an overlapping position in the anterior midline and then is sutured in place. It's important to note that if the sphincter defect is more than 180 degrees, this isn't possible to do both from kind of an anatomic standpoint, but also because you will injure the nerves that come in just posterior to that 180-degree mark. And so even if you get the muscle together, it won't function. So you do need to look at that on the ultrasound to determine whether, even in the presence of a defect, if a sphincteroplasty will be possible. Okay. So a 79-year-old woman presents with the complaints of a persistent rectal bulge, pain, and mucus discharge. On examination, you visualize the rectum extruding beyond the anal verge. What is the most likely diagnosis? Prolapsed internal hemorrhoids, rectal precedentia, rectal cancer, rectal intussusception, or an enteroceal? Okay, good. So the point here is that this is a rectal prolapse. If you visualize the entire rectum coming through the anus, then that is rectal prolapse, and rectal precedentia is an interchangeable term for that. A 70-year-old woman with a history of hypertension mentions to her primary care physician that she's noticed a rectal bulge that worsens with straining. She's referred to your office. On physical exam, she's found to have rectal prolapse. You review previous CT scans and you note that she has a redundant sigmoid colon. What management would you offer this patient first? A, an Altemeyer procedure, B, ventral rectopexy, C, a transabdominal rectopexy with sigmoidectomy, D, a DeLorme procedure, or E, biofeedback? Okay, so C is the correct answer, rectopexy with a sigmoid resection. It's important to note some things. So in a patient who has diarrhea, even if they have a redundant sigmoid, you probably shouldn't offer them a sigmoid resection as part of their prolapse procedure. But in a patient with constipation and straining, that is appropriate and has better outcomes. An Altenmeyer procedure is a perineal approach to prolapse surgery, and while that is it's a very safe procedure, it has a higher risk of recurrence, and so in a patient who's a candidate for a transabdominal approach, that's usually not the first choice. The other procedures that are listed are the ventral rectopexy is more often used for other defecatory disorders, although it can be used for prolapse, but doesn't include the sigmoid resection that this patient would benefit from. And biofeedback is not an appropriate first-line treatment for rectal prolapse because the patient will eventually develop incontinence due to the stretch on the sphincter muscles and the pudendal nerve. A 68-year-old man with a past medical history of COPD, diabetes, and cardiac disease presents to the emergency department with severe rectal pain and a rectal bulge. On physical examination, you visualize the edematous circular folds of rectal mucosa. What is the initial management choice? A, use table sugar to attempt reduction. B, apply steady, gentle pressure to attempt reduction. C, perform an Altenmeyer procedure. D, perform transabdominal rectopexy with sigmoidectomy. Or E, perform a Delorme procedure. Okay, so A and B are the top choices, so let's talk about that. So it's good that you all want to reduce it in the emergency department. That's the correct answer because you need to determine whether this is truly incarcerated or not, and you need to get it reduced before the congestion and edema create an incarceration or strangulation. The correct answer is B because you should apply steady, gentle pressure to attempt reduction, and table sugar alone is insufficient. However, table sugar can be a useful adjunct to a reduction attempt as it tends to pull some of the fluid osmotically out of the mucosa and can make it easier to reduce. Okay, a 60-year-old woman is diagnosed with a 4-centimeter left lateral anal canal squamous cell carcinoma. On physical examination, there is palpable left inguinal lymphadenopathy. Staging CT of the abdomen and pelvis and pelvic MRI imaging confirm slightly enlarged left inguinal lymph nodes. What is the next best step in management? A, fine needle aspiration of the left inguinal lymph node basin. B, fine needle aspiration of both inguinal lymph node basins. C, prophylactic left inguinal lymph node dissection. D, prophylactic bilateral inguinal lymph node dissection. Or E, chemoradiation. Okay, so A is correct because what they're trying to describe to you here is that the findings might be equivocal in terms of whether there's clinical lymph node involvement of this tumor. And so the FNA would really be done as part of the staging evaluation of this patient in order to try to sort that out with regard to their optimal treatment. Chemoradiation is the standard therapy for anal squamous cell carcinoma. However, if this patient had involvement of their inguinal lymph nodes, then that may change either the conformation of the radiation field that the radiation oncologists might choose, or it may influence the surgical approach if the patient fails that treatment. A 45-year-old woman with no significant past medical history presents for evaluation of an anal lesion. On examination, a 3 by 2 centimeter condylomatous appearing lesion is identified at the right posterior anal margin. The remainder of the external and anoscopic examination is normal. She is interested in a treatment she can use at home. Which of the following is the most appropriate topical therapy to recommend for treatment of this lesion? A, podophyllin, B, podophylox, C, trichloroacetic acid, or D, cryotherapy? Okay, so let's talk about this. Pedophilox is the correct answer. So you should, first let's talk about the way in which these are administered. So Pedophilox is the only one of these that is really prescribed for home use. So that is the main reason why it's correct. TCA or cryotherapy can be done in the office and are commonly used by us and by dermatologists for that. Podophyllin is a resin-based gel that's very irritating to tissue and in fact has some mutagenic properties. And so really there are not many of us who are using that even in the office anymore. So you want to make sure that you know the difference between these things for testing purposes. A 39-year-old woman presents with severe anal pain and purulent anal discharge. External anal examination does not reveal any obvious abnormalities. However, anoscopy shows severe erythema, edema, and purulence from the distal rectal mucosa. Which of the following is the next most appropriate step in the management of this patient? A, phoning her partner to inform him of a possible sexually transmitted infection. B, starting empiric therapy for HIV. C, empiric therapy for syphilis. D, empiric therapy for chlamydia. Okay, good. So empiric therapy for chlamydia. So in the absence of any other underlying inflammatory condition, the most likely reason for a patient to have acute proctitis is going to be gonorrhea or chlamydia. And so you want to treat empirically for those things and then initiate additional testing for other STIs that the patient might be at risk for. Okay. After emergent hemorrhoidectomy for incarcerated gangrenous hemorrhoids, a patient has developed anal stenosis. What are appropriate treatment options for this complication of hemorrhoidectomy? A, diverting loop ileostomy. B, bulk laxatives, dilation, and anoplasty if needed. C, reassurance as symptoms typically resolve with time. D, lateral internal sphincterotomy. Or E, sclerotherapy. Okay, good. B is correct. I don't think we need to spend much time on that one. Oh, there we go. A 40-year-old female with hemorrhoids was prescribed a diet regimen rich in fiber and adequate fluid intake during her last visit. Despite adhering to this for the last 3 months, she is still experiencing discomfort from her hemorrhoids and occasionally has to push them back in when she strains. She is offered rubber band ligation and is agreeable to the procedure. What statement describes the correct placement of the rubber band? A, mucosa only 2 centimeters below the dentate line. B, mucosa and underlying pile at the dentate line. C, mucosa only 2 centimeters above the dentate line. D, mucosa and underlying pile 2 centimeters above the dentate line. Or E, mucosa and underlying pile 2 centimeters below the dentate line. Okay, so let's talk about this a little bit. So anatomically, what you're trying to accomplish with a banding is different than what you're trying to accomplish with a hemorrhoidectomy procedure. So in a banding procedure, you're trying to get the redundant mucosa, and essentially you want to preserve some of that vascular supply. There will be fibrosis that happens during the course of that hemorrhoid kind of shriveling up and falling off. And that will actually result, if it works properly, essentially in the scar creating a little bit of a hemorrhoidopexy for the patient. You don't, of course, want to go below the dentate line. None of you really chose any of those options, which is good. But you want to understand the distinction, because when you are doing a hemorrhoidectomy procedure, you are kind of excising a lot of those ectatic vessels and ligating the vascular pedicle. And this is a little bit of a different principle. A 45-year-old woman presents to the emergency department 3 days after you performed banding of her right anterior and left lateral internal hemorrhoid bundles. She reports she initially felt well, but over the last 8 hours has developed severe anal pain and has been unable to urinate. Vital signs are temperature 38.6, heart rate 110 beats per minute, blood pressure 140/90, and respiratory rate 18 breaths per minute. She is unable to tolerate an anal exam due to discomfort. The next step in her management should be A, prescribe appropriate analgesics and outpatient follow-up, B, proceed to OR for removal of bands, C, proceed to OR for hemorrhoidectomy, D, CT scan of the pelvis, or E, proceed to the OR for debridement and drainage as needed. Okay, good. So E is the correct answer. So what's important for you to get from this question is that this is the most common presentation of pelvic sepsis due to a hemorrhoid procedure. It can be very subtle. It usually is delayed urinary retention and may just have some mild tachycardia and no other hemodynamic changes, as well as severe pain. So this patient may actually be developing tissue necrosis and needs to go to the operating room immediately for an exam under anesthesia and debridement of any necrotic tissue. A 26-year-old woman presents with a 1-week history of anal pain. The pain came on suddenly and kept her from going to work for 2 days, but it has lessened since. She has had no bleeding. On examination, she has a 2-centimeter dark purple bulge at the left lateral aspect of the anus that is exquisitely tender. The rest of the anus is normal. She takes warfarin for recurrent DVT. What is the most appropriate next step for treatment? A, excision of the lesion under local anesthesia. B, excision of the lesion in the operating room after transfusing FFP. C, topical analgesics, stool softeners, and follow-up. D, rubber band ligation of the lesion. Or E, incision into the lesion under local anesthesia. Okay, good. So there's a few factors in this question that should be guiding you towards conservative management of this patient. First, the description of this lesion is consistent with a thrombosed external hemorrhoid, and the patient's presentation is consistent with that. In general, we don't intervene surgically on thrombosed external hemorrhoids after about 48 to 72 hours, because the natural history of these lesions is that they will gradually improve after that point in terms of their symptoms, and the clot will eventually resorb. This patient has an additional risk factor for surgical intervention in that she's anticoagulated. And so you wouldn't want to do a hemorrhoid surgery on a patient who's anticoagulated due to the bleeding risk. And so this is actually a patient where if she presented even within 48 hours, one might even consider conservative management and counseling her on what to expect and treating her symptoms, as given enough time, this is likely to resolve on its own. A 19-year-old man presents to the office with complaints of anal itching and bumps. He is otherwise healthy and has had heterosexual contact only. On examination, there are 8 to 10 small perianal condylomata on each side of the anus, all separated by areas of normal skin. After failing topical therapy, he agrees to excision in the operating room. Which is the next best step? A, bilateral excision of the entire affected area. B, excision of each individual lesion. C, staged excision of the entire area on each side. D, staged excision of individual lesions. Or E, HPV injection into the involved areas? Okay, good. So B is correct, excision of each individual lesion. So in a patient where they just have small warts and they don't have high-grade dysplasia or a squamous cell carcinoma in situ, you don't want to do a large skin excision because they'll have some difficulty healing. It'll be very painful, and that's not necessary. You can excise or ablate each individual lesion, and that will most likely resolve their problem. Now, some patients will have recurrent disease, and you would monitor them for that over time. But a wide excision isn't indicated. A 37-year-old male with a history of a renal transplant presents with a cluster of cauliflower-like growths in the perianal region. Anoscopic exam reveals an additional lesion. What is the best treatment option for this patient? A, topical podophyllin resin in a 10% or 20% benzoin solution. B, excision of the lesions. C, cryotherapy. D, stop the patient's immunosuppressive transplant medications. Or E, intralesional injection of interferon. Okay, good. So excision of the lesions is correct. I think what they're trying to get at in this patient is that these may be larger or a little bit more extensive, and so perhaps topical therapy may not be recommended in the office. And so you would excise these usually under anesthesia if they're pretty extensive and there's anal canal disease. It would not be appropriate to stop a transplant patient's medications, of course.
Dr. Kraugat, thank you very much for leading us through that discussion of colorectal and anal disease. That was excellent. Well done.
Thank you.
Thank you. All right, and for our fourth section of our ABSITE webinar this evening, it's my distinct pleasure to welcome Dr. Timothy Vreeland. Dr. Vreeland is a hepatobiliary and surgical oncology specialist from Brooke Army Medical Center in Port Sam Houston, Texas. Welcome, Dr. Vreeland, and thank you for being here.
Thank you for having me. I just said that I was impressed by how many people are still on an hour and a half into it, so hopefully we can keep going.
All right, we've got your first question up.
Well, I think I have a second delay because I've been a little bit behind on the video. I tried reloading, but okay. So a 75-year-old woman with a history of uterine leiomyosarcoma, status post TH BSO 2 years ago, had chemo radiation, now with recurrence. She had surgery 2 weeks ago with debulking and extensive lysis of adhesion, small bowel resection, ileocystectomy, cystectomy, vaginal repair, and had 120 centimeters of small bowel remaining. She is now admitted for poor appetite, severe weight loss, and increased ileostomy output, over 5 liters a day. She denies any fever, nausea, vomiting, or abdominal pain. What is the most likely diagnosis? Acute intestinal failure, also known as short or small bowel syndrome, C. diff, viral gastroenteritis, or other bacterial gastroenteritis.
Okay, we have the response up.
Yeah, it must be just behind, but anyway, so the correct answer most people got it is A, acute intestinal failure, or, they call it here small bowel syndrome, or most people call it shortcut. So, risk factors for this, if you have an ileocecal valve, the number that most people remember is you want 100 centimeters of small bowel. If you don't have an ileocecal valve, in this case she has an ileostomy, so you'd like to have 150 centimeters of small bowel, so she's obviously at risk for shortcut. The treatment is basically upfront electrolyte replacement, try to slow the bowel movements down, so loperamide, fiber, try to thicken the small bowel contents. And then TPN is often needed in these patients as well. Try to do enteral feeds, but that can cause their ileostomy output to go up. So usually you need some IV replacement and often TPN.
All right, we have our next question.
I'm going to try to go off the slides just because I have such a delay. So 56-year-old woman underwent a total colectomy with ileorectal anastomosis for colon cancer. She was tolerating clear liquids, past inflative pain was well controlled. On postoperative day 3, she reports abdominal distension followed by nausea and bilious, non-bloody vomitus. On exam, bowel sounds are reduced with abdominal distension, no rebound tenderness. Vitals and electrolytes are normal. Abdominal x-ray shows uniform distension of the stomach, small bowel, and colon. What is the next step?
Okay, and answer is shown.
Okay. So, this is a patient who, has an ileus basically, so treatment for that, not overly complicated, basically make them MPO, put an NG tube in, decompress. And then, the key of multimodal pain management is you want to try to minimize narcotics. The other thing that could be included here is to optimize electrolyte management. That's the other thing that's helpful. But this is not overly complicated, as evidenced by how many of you guys got it right.
All right, next question.
So the next one, just referring back to the previous patient, what is the most likely diagnosis? Peritonitis, mechanical bowel obstruction, colon cancer, paralytic ileus, or stricture. I may have given that one away. That one shouldn't be too hard either.
Wow, 100%.
That's impressive. So paralytic ileus, again, we kind of talked about management of that. I will say, they give you a low dissection around the rectum, which is sort of the classic patient that gets this. There is some, some connection between dissecting down in the pelvis and getting ileus, probably from disruption of some of the nerves. Okay.
All right, we got our next question.
So the next one for the previous patient again, which of the following has been shown to reduce the risk of these findings? Early TPN, limited IV fluid replacement during the perioperative period, stopping patient-controlled analgesia postoperative day 3, use of LR for postoperative fluid replacement, or NG decompression for at least 2 days postoperatively.
All right, answer is shown.
Okay, so good, yeah. So this is basically an ERAS question. What are the things that are associated with ERAS? Limiting IV fluid in the perioperative period is certainly one of the things that helps rapid recovery from surgery. The other options, there's nothing specific about stopping a PCA on day 3, but minimizing narcotics, using multimodal pain management is certainly an aspect of that. LR versus NS is, not has very little to do with ERAS, so that's not related. And then keeping an NG tube in for 2 days has been shown to slow patients' recovery, so we try to get the NG tube out as quickly as possible for this patient, probably in the operating room, and then try to get enteral feeding going as soon as possible via PO if possible.
All right, good. Next question.
So a 47-year-old male underwent ileocytectomy for Crohn's disease. So that's enteric drainage from the midline abdominal wound 14 days after the operation. The fistula is pouched and puts out more than 600 cc's of drainage. What is the next best step in management? Re-exploration, fistular resection, bedside debridement, aggressive IV fluid hydration, or loperamide administration.
Okay, we've got some difference of opinion on this
Yeah,
one.
a little bit there. So I think the key here, again, we've gone over this, it's a test-taking skill, right? The question is, what is the next step? Not all the steps that are necessary, but the first step is a high output fistula, so that's one aspect of this question is anything over 500 milliliters a day is considered a high output fistula. So those patients are at significant risk for dehydration. So the initial step is going to be aggressive intravenous fluid hydration, where you got to keep up with their losses, check their electrolytes frequently. And then down the road, NPO, TPN, potentially loperamide. But again, for the test, and you got to read the question, and the best next step would be aggressive IV fluid hydration.
Next question.
I think my screen is finally caught up, which is good. So a 54-year-old woman with a history of recurrent small bowel obstructions and multiple abdominal surgeries presents to the emergency department. She has fever, tachycardia, hypotension, and enteric contents draining from a surgical wound 8 days after her most recent X-flap and small bowel resection with side-by-side stapled anastomosis. The most important factor in reducing mortality from a small bowel fistula is which of the following? Prevention of skin breakdown, early operative intervention, control of sepsis, waiting at least 6 weeks before operative intervention, or use of TPN. Okay, good. So yeah, the most important thing for reducing mortality is control of sepsis in these patients. So again, all these things are reasonable, preventing skin breakdown. Early operative intervention is generally a bad idea in these. The other option D, waiting at least 6 weeks, I would say waiting months is usually the best thing to do for a small bowel fistula. Use of TPN is often involved, but the most important thing to decrease mortality is early control of sepsis, and then again, catching up with their electrolyte losses and fluid losses. Okay, this one I thought was an interesting one to get in the mix here for the topic at hand. But a 67-year-old male is involved in a high-speed motor vehicle crash. He sustains multiple rib fractures, pulmonary contusions, necessitating endotracheal intubation with mechanical ventilation. On hospital day 5, he developed fever, purulent secretions, and a new left lower lobe infiltrate on chest radiograph. Which of the following laboratory findings would be most specific for securing a diagnosis of ventilator-associated pneumonia? Pleural fluid analysis with a specimen to protein lactate dehydrogenase ratio of 0.55, endotracheal aspirate with 75,000 CFUs per ml of strep viridans, BAL specimen with 150,000 CFUs per ml of Pseudomonas, protected specimen brush with 900 CFUs per ml of Staph aureus, and concurrent blood and urine cultures positive for Serratia. Okay, good. So BAL with 150,000 CFUs is the correct answer. Again, it's not important what the bacteria is. It's about CFU count. So the common ones that we look at for protected specimen brush, it's only 1,000. For BAL, it's greater than 100,000. And for endotracheal aspirate, it's greater than 1 million CFU. So that kind of makes sense. The further down you dive into the airway, the less kind of bacteria you would expect to find as a contaminant. So those endotracheal aspirates are going to be really dirty with contaminants, so you have to have a really high CFU of 1 bacteria to have a diagnosis. But for BAL, the number to keep in mind is over 100,000, so this patient meets that criteria. And then the pleural fluid analysis with that ratio, 0.55 would be a transudate, which would not be in line with a pneumonia. And then the last one, I think, was referring to basically diagnosing disseminated fungemia, where you have to have multiple cultures positive for a fungus, but that has nothing to do with a bacterial pneumonia. Okay, so next one, a 35-year-old woman with UC and primary sclerosing cholangitis is referred to you for epigastric pain precipitated by spicy food. LFTs are normal. Ultrasound shows a 6 millimeter non-mobile pedunculated lesion in the body of the gallbladder with hyperechogenicity. No acoustic shadowing. This lesion was not noted on an ultrasound 2 years ago. Multiple intrahepatic strictures are noted but are unchanged from previous imaging. Exam shows no palpable masses or tenderness. What is the next best step? Options are repeat ultrasound in 3 months, repeat ultrasound in 6 months, laparoscopic cholecystectomy, radical cholecystectomy without portal lymphadenectomy, and ursodiol. Okay, good. So a couple elements to this question. The non-mobile pedunculated lesion is a gallbladder polyp. The tricky thing here is that typically we don't recommend cholecystectomy for gallbladder polyps unless they're over 1 centimeter, except in the setting of PSC. So patients with PSC, any gallbladder polyp, it's recommended that they undergo a cholecystectomy. A patient who did not have PSC with this stem, I would agree with B being the right answer, repeat ultrasound in 6 months. And then you look for interval growth over 0.5 millimeter. In this patient, if they got that, they would be over 1 centimeter, and they would have an indication for surgery as well. But the key here is the PSC. And then the other thing that may come up is if they had a porcelain gallbladder or calcium in the wall of their gallbladder and a polyp of any size, they should also have a cholecystectomy. Next one, a 45-year-old male presents to your clinic for follow-up of a laparoscopic cholecystectomy performed 2 weeks ago for symptomatic cholelithiasis. Pathology report demonstrates chronic cholecystitis, numerous mobile gallstones, and a focus of gallbladder adenomytosis in the fundus that was not detected preoperatively. What would be the most appropriate next step in management? 4-phase CT of the abdomen and pelvis, CEA and CA19-9 levels, segment 4B5, liver resection with portal lymphadenectomy, repeat ultrasound in 6 months, or symptom-directed follow-up. Okay, good. So yeah, they're trying to trick you into thinking that adenomyomatosis is some cancer or something like that, but that's a benign finding that's often found in gallbladders with chronic cholecystitis, so there's nothing to do for that. So all the other answers are obviously wrong, but just, be aware that they may show you that on the test, and it's a benign finding. All right, so a 61-year-old woman underwent laparoscopic cholecystectomy for symptomatic cholelithiasis. Pathology showed a 0.5 centimeter poorly differentiated gallbladder adenocarcinoma invading into the perimuscular connective tissue. No invasion into the liver or serosa. Lymphovascular and perineural invasion are also present. The cystic duct margin and cystic duct node are both negative for malignancy. Staging shows no metastases. CA19-9 level is elevated at 253. What would be the next best step? referral to medical or radiation oncology for adjuvant chemotherapy with or without chemoradiation, PET scan, segment 4B5 resection, common bile duct resection with reconstruction and portal lymphadenectomy, segment 4B5 resection with portal lymphadenectomy, repeat CT of the chest, abdomen, pelvis in 6 months. Okay, good. So most people knew this one. So there always seems to be a question on gallbladder cancer on the ABSITE, so it's worth reviewing the T staging. So essentially T1A is in the lamina propria, T1B is into the muscle, and then T2 is beyond the muscle. The newest AJCC breaks it down. On the peritoneal side is T2A, on the liver side is T2B, T3 is into the serosa, and then T4 involves the portal vein, hepatic artery, or 2 or more adjacent organs. So the T4s are really aggressive. The treatment for gallbladder cancer, basically T1A, you can get away with just cholecystectomy. So if it's a T1A that's found incidentally after cholecystectomy, you're done. You don't have to go back. T1B and above gets a segment 4B5 with lymphadenectomy. And then the part there about bile duct resection, if the cystic duct margin is positive, then you have to go back and resect more cystic duct. If there's no more cystic duct to take, then you do a bile duct resection with reconstruction. So that's what they're getting at there. But in this case, the bile duct margin was negative. So I think it's worth just before the test looking over that T staging and knowing those, because it always seems to come up. 35-year-old woman with a history of laparoscopic appendectomy presents with right upper quadrant pain, scleral icterus, and a bilirubin of 4. Right upper quadrant ultrasound shows cholelithiasis and a 1 centimeter common bile duct with multiple filling defects. Follow-up MRCP shows stones in the common bile duct and in the common hepatic duct with a 5 millimeter cystic duct. Which of the following features is the strongest contraindication to a laparoscopic transcystic common bile duct exploration? Common hepatic duct stones, 5 millimeter cystic duct, the 0.5 centimeter common bile duct stone, 4 common bile duct stones, previous appendectomy. Okay, good. So most people got the right answer. So the contraindication, the strongest contraindication is common hepatic duct stones. So that comes down to kind of knowing the anatomy and the semantics of that anatomy. The common hepatic duct is the duct above where the cystic duct comes in. So you can imagine doing a transcystic common bile duct exploration is very difficult to get stones out above the cystic duct because you'd have to somehow get the catheter and balloon to flip up and then pull it back to the cystic duct. Just with the angle of the insertion of the cystic duct, that's very difficult to do. So that's a contraindication. The other main contraindications are a very small or friable cystic duct. They use less than 3 millimeters for that size. Any stone over 8 millimeters, so 1 centimeter common bile duct stone might be a contraindication, but a 5 millimeter, which is what they give here, is not. And then greater than 8 stones in the common bile duct, here they give 4. All right. A 60-year-old woman is undergoing a laparoscopic transcystic common bile duct exploration for common bile duct stones. Attempts at removing the stones using fluoroscopy have been unsuccessful. You are preparing for choledocoscopy. Which of the following is typically done in choledocoscopy? The cystic duct is dilated as much as possible to improve the likelihood of success. A Maryland dissector is used to help insert the choledocoscope. A balloon-tipped catheter is inserted through the working channel of the choledocoscope for stone withdrawal. The cystic duct is entered as close to the common bile duct as is safely possible in order to facilitate difficult stone extraction. And the cystic duct stump is typically closed with surgical clips. Okay, so this is a tough one, so we'll go over this. We can go answer by answer here. So the cystic duct is dilated as much as possible. That's kind of a little bit of a test-taking scale. It's not dilated as much as possible because you could overdilate it and make the cystic duct more friable, make it more difficult to close at the end. A Maryland dissector is used to help insert the cholecystoscope. You know, to be honest, I didn't love this question. They want to say that you're going to use an atraumatic grasper to help insert the cholecystoscope. So, you know, that's a little bit of semantics there, but you know, the idea is that a Maryland could poke through the back of the bile duct or something like that. It's a little more traumatic. A balloon tip catheter is inserted through the working channel. That's wrong because it doesn't go through the working channel. You slide it down the duct next to the cholecystoscope, so it's too big to go through the working channel, so you have to slide it down next to the scope. So that's why that one's incorrect. And then the cystic duct is entered as close to the common bile duct as safely possible. That's true. That's the right answer. And the reason is, you know, the cystic duct has valves along it, so if you go way out at the cystic duct infundibulum junction, you're going to have to try to pull the stones back through those valves, and that can be difficult and just make the whole thing more difficult. So you want to, you know, use as short a stump as possible on the cystic duct, but still have enough that you can close it. And then E is wrong because usually we close the cystic duct with an endoloop after a common bile duct exploration. So anytime you kind of are doing funny things with the cystic duct and dilating and things like that, a 5mm clip might not get across, so you typically use an endoloop. I usually use both endoloop and then clip next to it. But that's question or answer by answer what they're looking for there. All right, a 72-year-old man is undergoing an open common bile duct exploration for multiple common bile duct stones after an unsuccessful ERCP. The choledochotomy has been made and multiple stones have been extracted. The duct is ultimately unable to be cleared of stones. Which of the following is the most acceptable option at this point? Bile duct closure with continuous suture, choledochoduodenostomy, closure of the choledochotomy followed by insertion of a transcystic catheter to maintain biliary access, Whipple procedure, wide drainage, and postoperative percutaneous transhepatic cholangiography. Okay, good. So most people got the right answer, although catching up. So, you know, this is also a common oral board scenario, so you need to be kind of prepared for this, what you're going to do in this situation. So, you know, you tried to explore the duct and there's a stone down low that's stuck and you can't get it out. Choledochoduodenostomy is the answer they want here. So basically you're going to do some sort of choledochoenteric anastomosis. So, you know, either you bring up a roux limb and do a choledochojejunostomy, or you do a side-to-side choledochoduodenostomy because it's sitting right there. Closure of the choledochotomy with transcystic catheter, you know, that's not a terrible answer, but the idea here is they tell you in the question that they've already had an unsuccessful ERCP. So what are you going to do next? You're going to leave the catheter and then rely on ERCP, but they put that in the question for a reason, right? So after an unsuccessful ERCP, you're there doing surgery, so you have to fix the problem one way or another. So choledochoduodenostomy, I put a picture in, I think, just because most of you have probably never seen that, but this is the way it's described, is you basically do a side-to-side anastomosis. The duct is sitting right next to the duodenum there. You just do a poke or mobilize the duodenum and then do your side-to-side anastomosis. The one problem with this is that food particles can actually reflux back up into the bile duct, and you can get what's called sump syndrome. And so most people now would advocate for a defunctionalized limb, so bringing up a leukodejunum and doing a hepaticojejunostomy instead. But this is certainly an option as well. You see a 65-year-old woman in the office 3 weeks after an open common bile, after an open common bile duct exploration. She still has a T-tube in the common bile duct. A cholangiogram is performed that morning that shows 2 3-millimeter retained common bile duct stones. She is asymptomatic. Her total bilirubin is 0.8. What is the next correct step in the management of this patient? Proceed to the operating room for repeat common bile duct exploration. Admit to the hospital for IV antibiotics. obtain urgent ERCP and perform sphincterotomy, remove the T-tube in office as planned. The stones are small and will clear on their own. Keep the T-tube in place and repeat cholangiogram in 3 weeks. If the stones are still present, proceed with ERCP and sphincterotomy or percutaneous extraction via the T-tube. Okay, good. So you want to repeat, keep the T-tube in and repeat in 3 weeks. So this kind of gets down to if you have any obstruction of the duct, you don't want to pull your T-tube until you've given time for the tract to mature. So we use kind of the 6-week rule for any tract or sort of, inflammation to go down and all those things. So you want to leave this in for at least 6 weeks before you pull it. If there are still stones in the duct, that would cause some reflux. So leave it until 6 weeks, repeat, and then if they're still there, you can do ERCP or have IR, try to get the stones out via your T-tube tract.
Dr. Vreeland, I want to thank you very much for a tremendous review of that topic. I really appreciate you being here and all your help with our webinar this evening.
Yeah, thank you.
All right, folks, well, that's about out of time for what we have for our part 1 of our webinar, but don't worry, we have part 2 coming up. So based on popular demand, we heard from you all that you want to hear about some additional topics. We have arranged for a second webinar on January 14th of 2020. This will be covering some additional high-yield topics on breast disease, vascular, trauma, and a number of miscellaneous topics. This is right before the ABSITE, so I think it will be a high-yield and popular topic. In the meantime, I wish everybody a happy holiday season, a happy new year. Thank you very much for being with us tonight. I would just ask you to please give us some feedback on the webinar. In your app, there is going to be a link for the web survey, and we'd really appreciate your time taking it. Thank you again, and good evening and Happy New Year to all.